right, let's get started so we can stay on time. All right, everybody, welcome to the 2019 Darby Children's Research Institute. And this year's topic is Advances in Pediatric Kidney Research. A little bit about who Charles Darby is. The Darby Children's Research Institute opened in 2005. It is the largest and most comprehensive pediatric research facility in the Carolinas and is one of only about 20 in the country. The seven stories, 121,000 square feet building houses 150 state-of-the-art laboratories with 11 research programs dedicated to discovering the cures for a wide spectrum of diseases affecting children. It was possible made by significant contributions from philanthropic donors, including Department of Pediatric faculty themselves. And the building honors the former Department of Pediatric chair, Dr. Darby. And we would love to say thank you. I'm not sure. Oh, Dr. Darby, you're here. Thank you so much. This year is a great year because now we have a director of the Darby Children's Research Institute. He will be here a little later. His flight, he is stuck in Detroit, so he is on the way here with all that weather. But Dennis holds the Charles P. Darby Endowed Chair for Children's Research, and he's the director of the DCRI. He's also associate director of the Translational Sciences for the Hollings Cancer Center. He is a scientific leader in molecular mechanisms of muscle wasting conditions, including the cancer syndrome called cachexia. He's formally diagnosed in cancer patients and contributes to poor prognosis and reduced quality of life. Other research interests of his include pancreatic cancer that has the highest incidence of cachexia and childhood illnesses related to skeletal muscle defects, including Duchenne's muscular dystrophy and childhood cancer called rhabdomyosarcoma. So we are thankful now to actually have a formal director of the Darby Children's Research Institute. So more great things to come. We do want to thank our abstract review committee that was led by Dr. Basco. We had 67 abstracts submitted this year. And these were our reviewers. If I missed somebody, I'm sorry. We did have some last minute changes here and there, but we also want to thank the steering committee, Dr. Basco, Eskandari, Guttridge, Hamrick, Ryan, and myself, and then all of our poster judges today. And I think we've had a couple of additions in there also. So if your name's not on there, once again, I'm sorry. And then we do want to thank our sponsors because they do do a lot for us, and this event is made as nice as it is because of the generous support from our sponsors. So please make sure you stop by their booths out there and learn about the really cool equipment and products that we use to treat children with kidney disease. So advances in pediatric research. So we're really in the now. So before we can talk about the now, I wanted to give you a little bit of brief history of AKI. So one of the first times AKI was described in the literature was by Willen Cullen, and it was a series of books he wrote in 1777 to 84 about the practice of physics. And he wrote a chapter on nephritis and inflammation of the kidneys. And it was mostly about kidney stones, but in general, he did mention decreased urine output or difficulty making water. And at that time, he had associated with external trauma, heavy exercise, and perpetual fever. Now, for my GI colleagues, we always say that if there was Miralax in the water, that we would lose half of our business in nephrology. And even back in 1700s, he said, as the colon presses immediately on the kidneys, we should be particularly careful to keep it empty. He recommends a quart of thin barley water, which was a high fiber. So, so it's just amazing that they knew this even back then. In 1802, William Heberden did a chapter on ichthyuria, which he described as a total suppression, has lasted 7 days, and yet the patient has recovered. It has been fatal as early as the 4th day, but in general, those patients who could not be cured have sunk under the malady on the 6th or 7th day. And then a more detailed description came up by Dr. John Abercrombie in 1821 on observations on Escherichia renalis. As the disease seems in general to come suddenly, the peculiar symptom is a sudden diminution in secretion of urine, which soon amounts to a complete suspension of it. After several days, the patient began to talk incoherently and shows a tendency to stupor. This increases gradually to perfect coma, which in a few days is fatal. The occurrence of coma may be expected about the fourth or fifth day from the time when the secretion of urine becomes suspended. So even back then. And then the first creatinine assay, the Jaffe serum creatinine assay, was developed in 1886. And then in 1888, we really started learning about the pathology of the kidneys, where they talked about the parenchymatous degeneration of the kidneys in settings of AKI. However, before 2004, there was no consensus on the diagnostic criteria or clinical outcomes of acute renal failure, and that resulted in at least 35 definitions in the medical literature about what acute renal failure was. The situation of having various definitions gave to wide ranges of incidence and estimates of AKI, anywhere from 1 to 25%, and the mortality estimates from anywhere from 15 to 80%. So the term acute renal failure was replaced with acute kidney injury in 2004. It was described by the rifle criteria, which we now have P-rifle, pediatric rifle criteria. And it's not just acute renal failure, it encompasses the whole spectrum of the syndrome, from minor changes in function to absolute failure needing renal replacement therapy. But creatinine is not a good monitor, is not a good marker for AKI. Creatinine is a surrogate of function, not injury. And you have to lose around 50% of your GFR before you see a change in your creatinine. Some people say 30%, 50%. So we need earlier markers of this to be able to prevent. So research has come a very long way, but we have a long way to go. That's where Dr. devarajan comes in, okay? So he is the Louise M. Williams Endowed Chair, Professor of Pediatrics and Developmental Pathology at Cincinnati Children's. It's not all he does. He's the Division Director of Nephrology and Hypertension, Director and CEO of Dialysis Unit and End-Stage Renal Program, Director of the Stone Center. He's the Director for the NIH P50 Centers of Excellence in Nephrology. He's the Director of the Nephrology Clinical Laboratory, as well as the Director of the Biomarker Laboratory, the Director of the Pediatric Nephrology Fellowship Program, which is a highly sought-after fellowship, and he is co-director of the Office of Pediatric Clinical Fellowships. Plus, he is the Principal Investigator and Director of the NIH T32 program, so impressive, to say the least. He's had more than 280 peer-reviewed publications. He has done more than 200 national invited talks, and he is among the top 1% of researchers for most cited documents in the field. This is his current funding. I'm not going to go through it all, but he is highly funded and working very hard to answer a lot of these questions for us. So we are so honored today to have Dr. devarajan be our plenary speaker about biomarkers of acute kidney injury, from serendipity to utility. Thank you. And we might need Michael.
I didn't do it.
I did it.
You broke it.
I broke it. Here's this and here's, how do we get out? I did that. Okay.
It just didn't want to do it.
Oh, okay.
And then I'll make that disappear. There you go.
Wow. Thank you, Catherine. Thank you for that warm welcome. I wish my mom was here to listen to that. You know. Yeah, she always tells me she put me through medical school so I could take care of her when she was an old person. And what did I do? I go into pediatrics. She's still wondering why I'm not in private practice. But anyway, again, thanks so much. Thank you all for being here. This is an honor. This is a pleasure. What I'd like to do today is first go through a couple of disclosures that are important for all of you to know. So I am a co-inventor on some patents on the use of this biomarker called NGAL. And I have licensing agreements with some companies that allow us to translate that information to be able to use commercially. And so with that disclosure, what I'd hope to share with you today is to just, like Catherine even started telling you, what is the need for better biomarkers for acute kidney injury, which is abbreviated AKI. We don't call it acute renal failure anymore. That's because nephrologists don't use the word failure in anything we do. We're going to try to understand the strategies for developing and translating disease biomarkers and finally understand the current clinical status of one of these novel biomarkers today. So let's start with why do we need better biomarkers? Like Catherine said, the issue of even defining this problem came to light in 2012 when a group of nephrologists, generalists, and intensivists formed this Kidney Disease Improving Global Outcome Group, or KDIGO, and came up with a consensus definition that everybody could agree on, a definition that can be validated and used anywhere from pediatrics to geriatrics. And this is the definition I'd like to share with you, and I'd like to encourage all of you to use this in current and future studies and in clinical practice. So there is an increase in serum creatinine by 0.3, or an increase in creatinine by 50% from baseline. And there's a time limit to these. So the 0.3 should occur within 48 hours, and the doubling of serum creatinine should occur within 7 days. Or urine output is also very important, and a volume of less than 0.5 ml per kilo per hour for 6 hours. So this is the current definition of acute kidney injury. It's widely accepted, widely used, and because we now have a consensus definition, we can now begin to understand, finally, what is the real incidence of acute kidney injury in very large prospective studies done across the world. And I'm going to specifically share with you some of the studies done in children. Every study has to have a sexy name. So there's a few of them right there. I'm going to briefly tell you that the AWARE study was published in the New England Journal. The AWAKEN study was published in the Lancet. And the TRIBE and ASSESS studies were published in JAMA. So not unknown journals. And this has become now possible because of a consensus definition and everybody accepting the same language. So let's start with the AWARE study. It clearly shows that AKI is a global epidemic in children. And this is a prospective study of more than 4,400 critically ill children aged 3 months to 25 years. And they used the KDIGO criteria, which I just shared with you, to identify children with acute kidney injury. It was done all across the world, 32 centers, 4 continents, throughout a whole year, and it was a prospective observational study. And what it showed is that this is really not just a Western problem, it's a global epidemic. And these are the results. In their study, 27% of critically ill children, 27% developed acute kidney injury. 12% developed severe acute kidney injury, needing dialysis, and 11% died. So that is the best current study. It was just published last year, and it tells you that in any intensive care unit in the world, 1/3 of the children have acute kidney injury, and at least 10% are going to die. So this is the same similar study, but in neonates, and this was published in the Lancet just again last year. Another prospective study, 2,000 or so critically ill neonates from, 24 NICUs, 3 continents, and they used a slightly modified KDIGO criteria. And this is what they found. You're comparing here AWARE with AWAKEN. AWARE is in the PICU, AWAKEN is in the NICU. And what you see is the incidence of AKI is the same. Whether you're a newborn or whether you're a critically ill child, 30% incidence of acute kidney injury. And the death rate is the same, 10%, 12%. And look at the adjusted risk of death. So what this means is that the odds ratio of almost 2 tells me that if there are 2 identical children in the pediatric ICU, identical, one with AKI, one without AKI, the one with AKI has a 2-fold increased risk of dying with everything else controlled and everything else taken into account. In the neonate, it's even more. It's five-fold. So there's a 5-fold greater risk of death if you're a neonate with AKI compared to a neonate without AKI. And like I said, this is all over the world. So this is pretty alarming, pretty shocking, and I hope that all of you will appreciate that we're talking about a global epidemic. And there are many reasons for this, and we'll get to that if we have time later. So that's the short-term outcome, okay? AKI, you die. But what about the long-term outcome? What if you survive? So this is one of the studies in JAMA that we published looking at the consequences of acute kidney injury. And here this is, again, a prospective multi-center study after cardiac surgery in children. And we followed these children for 5 years. And we used the same KDIGO criteria. And first of all, what we saw was the incidence at the index AKI was 44%. So in other words, 44% of children who undergo cardiac surgery do get AKI. Well, what happens to them 5 years later? This is the data we published in JAMA. So what you're looking at is three different studies. One is the TRIBE study here in, blue. This is the ASSESS study, which is in red, and this is the NHANES study in purple. NHANES is a normal population study, and we're looking at the outcomes of hypertension, albuminuria, and low GFR. You can see in normal kids, the incidence of hypertension is very low, and the incidence of albuminuria is very low, and low GFR is almost unheard of in normal kids. But look at what happens to these kids when they have heart surgery and they're followed up for 5 years. The risk of hypertension in the TRIBE and ASSESS was almost 15% or more. So 15% of these children, even if they survive their AKI, in the next 5 years, they get hypertensive. About 15% get albuminuria, and they have a drop. More than 20% have a reduction in GFR. So what this tells us is that AKI is not a one-shot deal. Even if you survive down the line in 5 years, 15 to 25% of these children are going to end up with either chronic kidney disease or with albuminuria or with hypertension. Not good news. So take-home messages of what I've told you so far. AKI incidence, I hope you're convinced, is high, rising globally, but it really still lacks awareness. It has serious short-term complications, death, and serious long-term complications such as chronic kidney disease and hypertension. And the current diagnosis and treatment of AKI is very, very delayed. And that's what takes me to the next part of the story, which is why is the diagnosis itself so imprecise and so delayed? Like Catherine began to tell you, serum creatinine is the current gold standard. It's been used for 150 years. But even normal serum creatinine really varies widely with age, with gender, with diet, with muscle mass, metabolism, multiple medications, and of course, hydration status that all of you know about. In AKI, serum creatinine will take several days to reach a new steady state to reflect the degree of kidney dysfunction. Let me give you an example. So here I am, I have normal serum creatinine today, I promise. You take out both my kidneys right now and donate them, okay? Take them both out. What's my creatinine tomorrow? Normal. Believe me, normal. It's going to take 4 or 5 days for my serum creatinine to reflect the fact that I've got no kidneys. So it takes several days. There's a period, window of opportunity that we're missing if we're relying on serum creatinine. And finally, more than 50% of kidney function may be lost before even serum creatinine begins to rise. And the best example of that is a living donor kidney patient. When I donate one kidney to somebody, my serum creatinine still stays normal, even though I've lost 50% of my kidney function right away. So why did the good Lord give us 2 kidneys? So that we can donate one. But there is an urgent need for early diagnosis, folks. The early forms of AKI are not that bad, and they're reversible. And there's a direct correlation between duration of AKI and mortality. What we say is you snooze, you lose. With early diagnosis, we believe will enable timely institution of effective treatment. And you're wondering, sitting there wondering, well, what can the nephrologist do? What early treatment is this guy talking about? Well, if you're an animal model of acute kidney injury, you would be very happy to know that there are several paradigms we can use: vasodilators, growth factors, antioxidants, anti-inflammatory agents. And here are some examples which work very well in numerous animal models as long as they're given either before the injury or soon after injury before the serum creatinine rises. These studies have been done for the last 30 years. They're very effective. We've used all of these agents in humans in clinical trials as well as when we pray and hope for the kidney to wake up it doesn't work in humans. And it doesn't work in humans because we don't have a good biomarker. We wait till the serum creatinine goes up to 3 and 4 and 5, and then you call the nephrologist, we're not going to be able to do anything at that time. So really the paucity of early biomarkers has crippled our ability and your ability to institute timely therapy for AKI in humans. Here's a good example of a difference between two common clinical conditions, acute myocardial infarction and acute kidney injury. You all know from medical school that in acute myocardial infarction, over the last several decades, we've had increasingly sensitive and specific biomarkers of damage to the myocardium, not damage to cardiac function, but cardiac structure, myocardial damage. And that has resulted in multiple therapies and a dramatic decrease in mortality. During the same time, we in nephrology have made the following progress. Delayed functional marker, not a structural marker, and that has left us with only supportive care and that high mortality that multi-center studies have now shown. So we really need these early damage biomarkers for better understanding and for better treatment for AKI. Well, how are we going to discover these wonderful biomarkers? This is the best time in the history of mankind to be discovering biomarkers, not just for acute kidney injury, but for almost any disease, because we have some very exciting tools which are used right now in this building, and I'll share a couple of them with you. We can do unbiased gene analysis, genomics, next-gen sequencing, single-cell RNA-seq, and you can look for changes in kidney gene expression following acute kidney injury, and you can do the same thing for gene expression in any organ of your choice. So we have these very powerful unbiased gene expression analysis tools. In the AKI world, there's more than 150 publications looking at gene expression analysis in various kidney injury models. Or you can do direct protein analysis, proteomics, and you can use that for novel biomarker protein discovery. And again, like in the genomic world, there are more than 30 publications now, both looking at urine and blood from both animal and human models of acute kidney injury. I'm focusing on AKI, but the same technologies can be used for any organ, for any disease of your choice. And then we sit with bioinformaticians and put all this information together and try to digest what's happening. And there is a ton of information. And the other good thing is all of this is deposited in publicly accessible sites. So we can spend months, if not years, looking at all this data. And we try to do that, for example, in this publication that I'm sharing with you. And the one thing that comes out, at least in the AKI world, is that there is this gene and this protein called NGAL that I'm going to talk about today, which is by far the most commonly upregulated gene and upregulated protein. So when we saw that, we said, all right, here's our gold standard. Let's see if it works. The rest of the talk is going to be primarily on NGAL as a biomarker. And in the discovery phase, we found that NGAL is actually a protein that was already first discovered in neutrophils. So it's a neutrophil secondary granule protein, and that's why it's called NGAL, neutrophil gelatinase associated lipocalin. We also knew that there are small amounts of this protein normally produced in epithelial cells that are exposed to the environment, such as the lungs, the colon, and the kidney tubules. And in these organs, the normal job of NGAL is it's bacteriostatic. It engulfs iron. It's an iron chelator and therefore doesn't allow iron to be available for bacteria to multiply. So teleologically, the function of NGAL, at least in these organs, is as a bacteriostatic agent. Well, what's it doing in the kidney other than being a bacteriostatic agent? So here's a little bit of basic science. So what we try to do is look at the expression of NGAL in animal models. And here is a model of ischemic kidney injury where we take a mouse and clamp the renal artery for 30 minutes. And when you do that, you get ischemia reperfusion injury. And 1 day later, 24 hours later, finally the serum creatinine begins to go up. So for 24 hours, we don't even know that there's injury to the kidney. But if you take a little piece of that kidney out, within 3 hours, and you stain it for the NGAL protein, it lights up like a Christmas tree. And if you look at some high powers, these are the tubules, and you can see this punctate cytoplasmic distribution in the tubule cells, and that's very reminiscent of a secreted protein. And indeed, if you look inside the lumen, you'll see all these dots in the lumen. And that sort of was our tipping point, our aha moment, if you will, our serendipity moment. We didn't believe it. So we did some other stains of NGAL, and we saw that tubule secretion of NGAL even with other stains. So what that told us is that, okay, here's a protein that's dramatically upregulated in the kidney that's being secreted into the tubule. Voila, can we look in the urine and see if it's a non-invasive biomarker of what's happening in the kidney? After all, the urine is a window to the kidney. And again, long story short, if you look here, this is an animal model of acute kidney injury. This is time 0. This is time 2 hours. So the first drop of urine that comes out of these animals is blazing positive for this protein NGAL. And the serum creatinine, as I told you, doesn't go up till about 4 hours later. So at least in this animal model, it looks very good. But we still had a lot of work to do. And I'm not going to go through all this. It's a paper that we published in Nature Medicine, where we created what's called as an NGAL reporter mouse, such that every time NGAL is expressed in this mouse, we can track it by using a diffusion reporter called luciferase or cherry. So we put those genes right upstream of the NGAL promoter such that every time the NGAL protein was expressed, gene and protein, these proteins would also be expressed. So we had a way of non-invasively tracking NGAL expression in these animals. And this is what we saw. This established not only the time course, but importantly, the organ specificity. Because the big question is, okay, this is NGAL. You're looking at NGAL in the urine. Is it coming from the kidney? Is it coming from the bladder? Is it coming from white blood cells? Where is it coming from? It's coming from the kidney. And I'm going to prove it to you right here. So this is a unilateral left kidney ischemia reperfusion injury in these animals. And they're expressing the NGAL reporter gene. So you can see that when I injure only the left kidney and watch this animal, within 3 hours, we start seeing this glow. And this glow gets even more at 6 and 12 and 24 hours and finally goes away. And we know this is the kidney and no other organ, because when we open up the animal and cut open the kidney, look at that. The left kidney glows, the right kidney doesn't. Left kidney glows, the right kidney doesn't. And no other organ is glowing. So when we have created a specific left kidney injury model, it's only the left kidney that expresses NGAL. And perhaps what's more important is that this same time course can be tracked in the urine of the same animals. So you can see within 3 hours, the urine is blazing positive for NGAL. So this establishes not only the time course, but also the organ specificity. So that quietened all those critics that told us that, oh, your NGAL is coming from somewhere else. Very important. No NGAL in pre-renal acute kidney injury. We all deal with this problem where a patient presents to you with an increase in serum creatinine after maybe a dehydration and fever for a day or two. The creatinine is up and you're wondering if this is pre-renal reversible acute kidney injury or is this the real serious type of intrinsic acute kidney injury. What this tells you is that you can rely on NGAL for making that differential diagnosis. So this is an animal, that same animal, reporter. We have dehydrated this poor animal to the extent that the serum sodium has gone up and the serum creatinine has gone up. 60 hours of dehydration. Look at that. Nothing in the kidney. No NGAL in the kidney. The kidney, as far as NGAL goes, looks pristine. So what that tells you is that you actually need structural injury to the kidney. This functional acute kidney injury will not result in an overexpression of NGAL. And the translation of this to the human I'll come to in a minute. All right, translation. So we have all this animal data, but before we start using this in humans, we had to do two things. We had to first create assays that are doable and measurable in humans. And those are ELISAs that we created in our lab. And perhaps more importantly, we needed to go to the dark side and talk to industry and tell them to take our assays and put them into commercially available platforms that are present in all hospital laboratories. And thankfully for us, industry partnered very closely with us, and we're now able to report to you that those ELISAs have now been translated to standard clinical platforms that are available in any hospital anywhere in the world. And so because of that, there has really been an explosion of NGAL use. More than 30 hospitals in the US alone now use it routinely. It's globally launched, and there have been an explosion of studies looking at NGAL. I'm going to focus on three big buckets today. One is cardiac surgery, the other is critical illness, and the third is nephrotoxins. These are the three commonest causes of acute kidney injury that we see in tertiary care centers. And so we're going to look at the use of NGAL for predicting acute kidney injury in these three buckets. We're going to look at the use of NGAL for differential diagnosis of acute kidney injury, and finally for prognosis. So let's start with AKI prediction. If all those animal studies were right, does it work in humans? Now that we have all these beautiful tools to measure NGAL in humans. So this is the first study we did. We published it in the Lancet in, I think, 2005. Simple study. 71 children undergoing cardiopulmonary bypass, single center study. We just took urine and blood from these patients, measured NGAL before and serially after surgery. And we used that KDIGO definition of acute kidney injury, which is the 50% increase in serum creatinine from baseline. So you know, that occurred 1 to 3 days after the surgery. The injury occurs when we put the child on cardiopulmonary bypass, but the increase in creatinine takes 1 to 3 days. And this is what we found when we looked at the urine NGAL in these children. In red are the children that never ever got acute kidney injury. And you can see that their urine NGAL stayed below baseline throughout the 5 days of this study. Look what happens in the children that got acute kidney injury as defined by an increase in serum creatinine, which, like I said, occurred 1 to 3 days later. Within 2 hours of starting the child on bypass, we get this massive increase in urine NGAL. Only in the patients that are destined to get an increase in serum creatinine later. And that peaks at about 6 to 8 hours, but stays up above baseline throughout the study. So what this told us is that this is probably a very good marker, at least an early marker, but how good is it as a diagnostic tool? In order to do that, we had to go rocking and do what's called as a receiver operating characteristic curve, or a ROC curve, and calculate what's called as the area under the curve. So the ROC curve is constructed by plotting sensitivity versus 1 minus specificity. And if you have an area under the curve that's 0.5, that's like tossing a coin. It's no good. But if you have an area under the curve of 0.75, that's indicating a good biomarker, and anything in the 0.9 range is an excellent biomarker. So when we put this test to the NGAL test that we did, this is what we got. We got a curve that gave us an area under the curve of 0.99, which is drop dead gorgeous. Okay? Translation, 2 hours, urine NGAL. The patient is still in the operating room with the chest open and with the cardiac surgeon trying to fix the defect. Within 2 hours of starting cardiopulmonary bypass, you give me 1 drop of urine, and I can tell you with 99% accuracy who is going to get an increase in creatinine 3 days later. Impressed? Thank you. People were not impressed. But here's the first meta-analysis that we did of all the studies looking at cardiac surgery, both in adults and kids, back in 2014. And even then, there were about 30 papers that were already published at that time, including the one we just showed you. And thousands of patients, thousands of AKI events, and quite simply put, the test stood the test of time. The area under the curve remained quite high, 0.82, 0.83. Good sensitivity, very, very good specificity. And the specificity actually over the years has gotten even better and better and better, such that I can tell you that the negative predictive value is fantastic, which means if you have a patient, you're worried about kidney injury, I don't care what the serum creatinine is. If the NGAL is low, that patient don't got. That's my Kentucky accent coming up. Don't have acute kidney injury, okay? So that's the cardiac surgery study. And since then, there have been another 30 publications that have validated the same thing. Let's move on to another common condition, critical illness. So here's a study we did in patients who presented to the emergency room for anything, for sepsis, for dehydration, for pneumonia, for whatever. They were admitted from the emergency room and we followed them in the hospital, but we got a urine NGAL at the time the patient presented to the emergency room. Okay, what's your name? What's your social security number? What's your insurance? I want a urine sample for NGAL. They did it, okay? And then we admitted them, and then we defined acute kidney injury as a new onset, 50% increase in serum creatinine from the baseline, which was sustained for at least 3 days. So if, in other words, this patient got an increase in serum creatinine, which got better with fluids and your great management in the hospital, that's not true AKI. That's pre-renal AKI. So here's what we found in that study. 4 buckets. Completely normal kidney function, patients with chronic kidney disease, meaning those that already had an increase in serum creatinine. Patients with pre-renal azotemia, which means had an increase in serum creatinine, got better in 2 days. And patients with true acute kidney injury, with structural kidney injury, which did not get better for 3 days. And these are the admission urine NGALs. This is the time when we got the NGAL level before the patient was even admitted to the hospital. Remember, this determination took us 3 days to figure out, right? But if you look at the urine NGAL at the time of admission, the area under the curve for prediction of this AKI, true AKI, was 0.95. Translation, patient gets admitted to the hospital. You get a drop of urine or drop of blood, measure the NGAL level. You can be 95% sure who is going to end up with a true structural acute kidney injury versus somebody that just has pre-renal, volume responsive, reversible acute kidney injury. So think about how this might be able to help you in the emergency room to triage your patients. Even if a patient has a high NGAL, high creatinine, if the NGAL is normal, you can be pretty sure that this is not going to be a dangerous type of acute kidney injury. You can give them fluids, you can send them home and get them checked out the next day. Whereas no matter what the creatinine is, if the history is consistent with acute kidney injury and your NGAL is elevated, that's a problem child. That's the one that I would probably want to get admitted and followed because there's a 95% chance that that patient has true acute kidney injury. Impressed? They didn't believe it. So here it is. Here we go. By 2014, an additional 25 publications, many, many thousands of patients. And look at that. The area under the curve still 0.8. The test is surviving the test of time. Finally, contrast. One of the most common nephrotoxins, we give about many, many millions of contrast doses every day in the US alone. And it is a nephrotoxin. And so we try to test, and most of the time we miss it completely. Nobody even looks for a nephrotoxic injury after routine contrast administration. So we studied 91 children who got contrast. These are all cardiac patients. And we did the same thing, measured urine and blood NGAL before and after. And we defined the AKI the same way, and here's what we found. This is plasma, this is urine. It works just as well in both biofluids. You can see within 2 hours of giving contrast, the ones that ultimately had an increase in serum creatinine, which occurred again 2 to 3 days later, within 2 hours of giving contrast, there's this very strong signal, both in the blood and in the urine. And the area under the curve there is greater than 0.91. So again, translation, what this tells you is that you give contrast before you send the patient home, get a drop of blood or urine, measure this biomarker, you can be 90% sure who is going to truly get an increase in serum creatinine 1 to 3 days later. It took a lot of studies from all over the world to prove us right again. So here are the first 15 studies. Look at that area under the curve, 0.94, 0.91. Okay, so we can predict acute kidney injury in at least these 3 conditions. And I don't have time to show you, but there are several other clinical conditions that lead to acute kidney injury where you can use this biomarker. What about the differential diagnosis that we began to talk about? Okay, here's a big study that we did in 3 different emergency room settings, more than 1,500 patients. And we did the same thing, measured urine NGAL before we admitted the patients. And we separated these patients into intrinsic AKI, which is an increase in creatinine sustained for 3 days or more, versus pre-renal AKI, which is the same increase or more, but reversed with fluids. Asking the question, can an admission level NGAL differentiate between these 2 groups of patients? And the answer is yes. Here is pre-renal AKI in thousands of patients. And look at the value, very low, 50, 60, whereas look at the ones that had true intrinsic acute kidney injury, way up here, okay? And I've drawn this line here at 150. So a urine NGAL concentration of 150 was able to differentiate 100% of the time, those with pre-renal AKI versus those with structural AKI. Please remember this number, 150. We're going to come back to this. And there's going to be a test at the end of this, so don't go away. Critical illness, many, many other studies, again, validated what we had found in that study. Well, what prognosis? Okay, you can predict acute kidney injury. You can differentiate pre-renal versus intrinsic renal. But what do you really care about? You really care about who is the patient that is not going to need dialysis, who's the patient that's going to need ICU care, who's the patient that's going to die on you. So can we use that admission NGAL, that initial NGAL, to predict these bad outcomes? And the answer is yes. There's a bunch of papers that were published in the critical care setting. The authors are here. And we looked at the ability of that admission NGAL level to predict who is going to get or who's going to need renal replacement therapy anytime during that hospitalization. It could be a week later, it could be 2 weeks later. And the overall area under the curve came out to be 0.8. So again, what that meant is that when you admit a patient, you can predict with 80% accuracy who is going to need dialysis during that hospitalization. Again, tremendous impact and implications for how we triage our patients. It's not a perfect marker. There are confounding issues. Again, I'll share some of them with you. One is patients with sepsis. 2 is patients with UTI. 3 is, like we discussed, pre-renal AKI. And 4th is chronic kidney disease. Let's look at how NGAL performs for diagnosis of AKI within these confounding settings. So here's the first study we did in patients with sepsis, just sepsis. We just measured NGAL in all these kids in our ICU. And what we found is that normal kids had no AKI and had no NGAL in the urine and blood. Patients with SIRS already started getting an elevation in plasma NGAL, and the ones with septic shock already with or without AKI. So this is the confounding issue here. Just having sepsis can increase your plasma level of NGAL. So now that's a problem, right? Because sepsis is an important cause of AKI. Turns out that it's okay, because if you take those same patients and parse them out into the ones that got AKI versus the ones that didn't get AKI, we saw this big difference. So that the ones that never got AKI, even though they had sepsis, still stayed in this pretty low range of about 250 to 300, whereas the patients with sepsis who did eventually get AKI were in the thousands. So you can still use this biomarker. You just have to change the cutoff level a little bit. What about UTI, pre-renal CKD? So we did this large study when we measured NGAL in all these patients. These are urinary tract infection patients. You can see them here. These are the numbers of patients. This is pre-renal, this is chronic kidney disease, and this is true intrinsic validated acute kidney injury. And these are all measurements at time 0. Again, that 150 number becomes very useful because you can see that although all of these patients with these confounding variables had a value of NGAL slightly above control normals, none of them reached that level of 150, whereas in the AKI world, true intrinsic AKI, they were all in 300 to 350 range. So you can still use this biomarker even with these confounding issues and use it to predict true structural AKI. Okay, and a lot of other studies have come out showing that you can use AKI prediction even in patients with sepsis. All right. It has continued. The explosion of studies has continued. And now there are 5 big meta-analyses of patients, many, many, many thousands of patients that have now been studied all over the world, okay, in all forms of AKI or in specific forms of AKI. And when we sit down and put all this information together, we end up with 30,000 patients that have been examined so far. And this is what we find. We find that the NGAL diagnostic accuracy for AKI detection is still pretty high. We find that the cutoff of less than 50 nanograms per ml effectively rules out AKI. So what that means is that if you no matter what the patient has, no matter what the creatinine is, no matter what the cystatin C is, if the NGAL is below 50, you can be reasonably or pretty sure that we don't have structural damage to the kidney at that point in time. And the ones that are above 150, that strongly predicts acute kidney injury. So this is where we are as a result of more than 30,000 published patients. And so we're going to take that information and then take it to the point of how we can use that in current clinical status in the next few minutes. So here's what we do. Okay? We measure NGAL not in everybody, but only if AKI is clinically suspected. If there is a reason you suspect the patient might have acute kidney injury, it could be a nephrotoxin, it could be dehydration, it could be sepsis, it could be whatever. We do measure NGAL in all those patients. And if it's less than 50, we're done. That rules out AKI. Don't bother me. Okay? You can repeat the measurement if it is clinically indicated. So today NGAL is normal. Tomorrow you give them gent and whatever and contrast. You may want to measure NGAL again. So it's a day-by-day decision. But if it's less than 50, we're good. That 50 to 150 has turned out to be what we call a gray zone. And it turns out that every clinical assay in medicine has a gray zone. And if we find that gray zone, then again, we would repeat the measures. If it's 70 today and it's 140 tomorrow, well, that's telling us something. If it's 70 today and 60 tomorrow, that's telling us you probably don't have AKI. So it's not only a static test, it's a dynamic test. And if it's already in the 150 to 300 range, and you're suspecting acute kidney injury, you put the clinical and the biochemical factors together and you say, all right, this patient has a high risk for true structural acute kidney injury, not the reversible prerenal type. These are the patients that we obtain daily NGALs on. We obviously monitor them very carefully for fluids, electrolytes, kidney function. We remove any nephrotoxins that we might be giving them. We assiduously maintain their blood pressure because in this situation, a low blood pressure can do a lot of harm. We are very careful about their fluids because fluid overload can do a lot of harm. And then we consider many of those other preventive measures that have worked very well in animal models. Now, what if it's about 300 already? Now, that's scary, honestly, because that tells me this patient is a high risk for severe structural AKI, perhaps is going to need dialysis sometime during this hospitalization. So we not only do all of the above, but we also consider early dialysis. Why wait till the patient is 20% fluid overloaded and has a creatinine that's 10 times normal? We will already start making plans for early dialysis. So that's our approach. And now I'm going to share with you 3 stories, true stories, all happened in the last 6 to 12 months. Here you go. This is cardiac surgery. This is a boy, 14-year-old. This is your test, by the way. He had critical aortic stenosis, and he underwent surgical repair with cardiopulmonary bypass time of 120 minutes. And 3 days later, he got AKI. He got oliguria, he got edema, he got an increase in serum creatinine. That's, any medical student knows that's clinical AKI. We all also know, even before we touch this patient, that he has multiple risk factors for AKI. He's got critical aortic stenosis. He's got decreased perfusion to his kidney. It's very likely that there is ongoing kidney injury. And he had a long bypass time. That is a well-known risk factor for acute kidney injury. So bypass itself is a risk factor, and a period of 120 minutes is an even bigger risk factor. So knowing all this, we monitored this patient with serial NGALs, and this is what we found. That first preoperative urine NGAL, even though we were worried about AKI, was 40. What does that tell you? That's right, he's fine. He does not have true structural AKI. I don't even care what the serum creatinine is. This patient does not have structural AKI. Even though he has critical aortic stenosis, his kidneys, which are the smartest organs in the body, have adopted, and are doing okay. So after cardiac surgery, within 4 hours, his urine NGAL is 195. Creatinine is normal. What does that tell you? He took a hit, absolutely, absolutely correct. So that's what we said. We predicted structural acute kidney injury in this patient, even though his serum creatinine was normal. So that's what we did. We monitored his creatinine and gal. We stopped all the nephrotoxins, had a fight with the cardiac ICU, but they finally agreed. We maintained normal blood pressure and started some other preventive measures. And then 3 days later, clinically, he still showed some evidence for acute kidney injury, and his NGAL was 80. What does that tell me? That's absolutely right. The cardiac ICU was telling us, okay, let's start dialysis. This patient has AKI, the creatinine is up, the fluid overload is there, you've got oliguria, what are you waiting for, you guys? Get your backside in and start dialysis. But the urine NGAL was 80. We said, chill, guys, because that tells us that he is recovering from AKI, right? And so we held off. And you know what happened? In the next 2 days, the kid opened up, became polyuric, edema went away, creatinine normalized. We were right. Actually, NGAL was right. True story, okay? So what that told us is that preoperatively, we were able to rule out AKI, so we didn't have to worry about AKI. 4 hours later, the patient showed some structural injury. We prevented AKI, and then 3 days later, even though clinically the patient looked like he was going into AKI, we were able to predict recovery at that time, and we held off on dialysis. This is a more complicated story. Sepsis. 18-year-old boy, pre-med student, doesn't take care of himself, comes in with appendicitis and suspected perforation. In fact, he was the son of one of my best friends. So he underwent emergent abdominal surgery, and he did okay initially, but then 3 days later, he developed sepsis, polymicrobial sepsis from that perforation. And we started treatment with broad-spectrum antibiotics, and 6 days later, he got AKI, the same thing. Decreased urine output, increase in serum creatinine, edema, clinical AKI. We had a lot of risk factors for AKI. Clinically, he had perforated, he underwent abdominal surgery, he had sepsis, he had nephrotoxic antibiotics. I'd be surprised if he didn't get AKI, and he did. But after the surgery, his NGALs were in the 200 to 300 range, although his creatinine was normal. This is the usual story in these patients. What's that tell me now? Okay, it told me don't send him to the floor, keep him in the ICU, watch him carefully. He's probably going to go into true structural AKI. And that's what we did. 3 days later, his creatinine is still normal, but he's now septic, and his NGAL is now 4,000. Serum creatinine is still normal. What would you do? Yeah, we started worrying. We started sweating. This told us that he has structural AKI, severe structural AKI. We stopped all his antibiotics. We at least changed all of them. We initiated very tight fluid control in this patient because, as you know, in this situation with sepsis, fluid overload is very bad for you. And we prepared. We started talking to the family. Even though the creatinine is normal, I'm telling you this patient is going to need dialysis. And so we started preparing for that. And then 6 days later, the creatinine finally slowly begins to creep up. 2.6. Remember, this is a big 18-year-old boy. So 2.6 is nothing to worry about too much. Not enough to start dialysis. But look at the NGAL. It's now 6,000. Now what? Well, now begins the big dialogue, right? What we said is, let's start CRRT because we don't need to wait for that fluid overload, for that potassium to go up to 7, for that creatinine to go up to 8. We don't need to. The writing is on the wall. It's telling us that this patient is going to get into serious trouble if we don't preempt and treat right now. And we did. So in this case, we were able to use NGAL to convince our colleagues to early start of renal replacement therapy. Last story, and again, a true story. True story. This was sent to me by email, and this is a very famous kidney pathologist, adult of course, from a very famous US hospital up in the Northeast. We won't tell you which one. He was on vacation with his wife in Italy, okay? He presents to the emergency room there with vomiting, diarrhea, and a creatinine of 2.5. Famous kidney pathologist calls a world-famous nephrologist up in his world-famous US hospital. He says, come back home right away. You need a biopsy. We need to start dialysis. You probably have bad interstitial nephritis, He's out there in Italy, okay? This test is launched all over the world. And in walks a very kindly Italian ER doctor and says, Your urine NGAL is 42. What would you do? Would you believe the famous US nephrologist, or would you believe the kindly Italian emergency room doctor? This is what happened, guys. The doctor predicted he had pre-renal azotemia. He gave him some fluids, sent him home to his hotel. Next day, his creatinine was normal, fully recovered, happily completed his vacation, saved his marriage. I still have the email in front of me. It says, "Thank you, Dr. D, you saved my marriage." True story. What's next? What's next for these AKI markers? We're not there yet. Like Catherine said, we still have a long way to go. First of all, we always teach our fellows and junior faculty that it should be used in the context of the clinical setting, and it should improve upon our clinical acumen, our clinical scores. So a good biomarker will make a good doctor better, but will not make a bad doctor good. So ongoing studies are now using AKI biomarkers such as NGAL as entry criteria for all these AKI therapeutic trials. And we're also using it as an endpoint. Instead of using serum creatinine to reflect improvement, we're using improvement in biomarkers to reflect response to therapy. And there's about 150 studies right now going on in clinicaltrials.gov looking at NGAL for either early diagnosis or for early prediction of response to therapy. And here's one study that we're doing. This is NIH funded. We take patients who are at risk, clinical risk for acute kidney injury, and we measure this biomarker. We have patients who have normal NGALs and patients who have high NGALs. If they have normal NGAL, that biomarker is telling us that they don't need any specific intervention for acute kidney injury. So we just follow them, give them routine standard of care, and we would predict that the outcome will be that the NGAL will stay normal and that patient will never develop acute kidney injury. But whereas if you have a patient at risk and we don't even care what the creatinine is, what if the patient's already got a high NGAL? So we're cherry picking these patients and we're saying, okay, we've got a patient at high risk for subsequently developing acute kidney injury. Let's randomize them to standard of care or placebo or any specific treatment. I shared with you 10, 15 treatments that are very, very effective if given early enough, if given before the creatinine goes up. And then we predict that the ones that get standard of care will continue to have high NGAL levels and develop true AKI, whereas the ones that respond to our intervention, we will see an NGAL go down and eventually we'll see less AKI. So these are studies currently in progress. They're working very well and they're being done in many, many centers across the nation. It takes a village. It takes more than a village to do stuff like this. And this is just an example of some of the PIs in many, many centers that have collaborated with me on all those NGAL studies that I shared with you. I want to give a shout out to my partners in industry, Abbott, BioSite, and BioPorto. They have taken these wild ideas and invested a lot of time and money into creating assays that anybody anywhere in the world can use. And of course, none of this would have been possible without very generous funding for research. Thank you for your attention. I'm happy to answer questions.
So the first question that I've already gotten about 5 texts about is it going to, do we have it here? We will. Our lab is working on validating the assay right now. We should have it clinically by May. So you should be able to order this clinically in the near future. So that one I've already gotten the question.
And you all already passed the test, so you're good to go. Ma'am.
Thank you for a terrific talk. I'm particularly interested, does NGAL retain its capabilities when you look at very opposite ends of the spectrum? So for instance, in my world, a stem cell transplant or oncology patient is neutropenic with an ANC 0 for 3 weeks. It's still predictive. And on the opposite end, a sickle cell patient who has constitutively activated neutrophils, how does it work for those patients?
Yes, absolutely. Great question. And the question is, where does this urine NGAL or plasma NGAL come from? It comes from the kidney tubules. It comes from the distal nephron, and it is secreted actively into the urine and into the blood. And the form of NGAL that is produced by the kidney in response to injury is very different from the form of NGAL that is present in, say, white blood cells. White blood cells have dimers, trimers, tetramers. We're talking about monomers. And those companies have been very good about creating monomer-specific tests so that when you measure NGAL with any of these company standards, you're actually measuring the NGAL coming from the kidney. Okay? Another way to put it is that you can pump me with 100 milligrams of NGAL. NGAL is normally in nanogram amounts in the blood. You can put 100 milligrams of NGAL in my vein and nothing comes out in the kidney. And that's because the kidney, the smartest organ in the body, reabsorbs everything and doesn't allow that NGAL to appear in the urine unless the kidney is damaged. When the kidney is damaged, the NGAL expression goes up more than 100-fold, and that's when we see it. We've specifically tested exactly what you're asking for. So in neutrophil-depleted animal models, there is no NGAL in the urine unless they have true acute kidney injury. We've tested it in sickle cell, and we've published this. It's a good marker. It's not better than microalbuminuria yet, but it's almost as good to detect kidney damage in sickle cell patients. And in the BMT patients, yes, it's absolutely very, very useful. In fact, it predicts who is going to get, for example, TA-TMA a couple of weeks before you see the drop in platelet count and haptoglobin and things like that. So short answer is it is completely independent of the white blood cell. A great question. Ma'am.
Have you looked in all ages of patients, neonates?
Great question. So most of the studies have been done in infants at 3 months of age till octogenarians. In the neonate, there are several, there's about 10 papers that are published, and the results are a little bit up and down. And the reason is as follows. NGAL is actually very important biologically for kidney development, and it is overexpressed in the developing kidney. So the more premature you are, the lower gestation age, you're going to have increased NGAL levels simply from the fact that you need that as an iron transporting agent in the fetus. So we need to take that into account. If you do take that into account, it does turn out to be a good biomarker in the neonatal ICU. So again, it's a question of cutoffs. The cutoff in the neonate is going to be a little higher than the cutoff in a patient who is otherwise a child or a normal adult. And the cutoff is again going to be different in patients with sepsis who have an increase in NGAL even without acute kidney injury. Sir.
Awesome talk. I'll disagree with you about the organ being smart, but being smart. But that's
Let's take that outside.
So my question is, you mentioned the dialysis endpoint, either preventing it or giving it early. Anyone who prevents dialysis comes out as a hero. If you give dialysis, it's hard to know whether what you did really helped or would they have gotten better on their own. Have you guys done the studies to see what level of NGAL increase or even the predicted outcome of dialysis versus not dialysis?
Absolutely, yes. Another great question. So NGAL and some other biomarkers are also great biomarkers of improvement or of regeneration and repair. So we and several others have done this study where you have a patient on dialysis already, and boom, 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 we're serially measuring NGAL levels. And one fine day, the NGAL level goes down. Nothing else has changed. The kid is still anuric. The creatinine is still kind of elevated. And we're still doing dialysis, but the NGAL begins to go down. That tells us that there is repair going on, and that kidney is beginning to wake up. And so it's an early signal of regeneration and repair. And so we can use it as a, and we've done that actually. When we see the NGAL levels go down, we'll say, okay, we're going to hold off on dialysis today, see what happens. And the next 2 or 3 days, the kid starts peeing. So short answer is you can use it as a biomarker of recovery. Sir? Ma'am?
I was curious in your first case, you mentioned preventative measures, and you alluded to a number of preclinical trials earlier in the talk that work like magic in animals but fail miserably.
That's right.
So are you using any of those off-label clinically right now in your people? Which ones are you using?
Yeah, and promise you won't tell anyone. So the ones we're most commonly using is phenoldiazepam, which is a version of dopamine that is very renal specific, and it causes renal vasodilation. So ongoing studies are looking at early initiation of phenoldiprem. Also, we're looking at early initiation of renal replacement therapy in these patients, and we're finding that the ones that are predicted to have AKI and undergo early RRT are the ones that have shorter length of stay in the hospital, less ventilation time, less pressor requirement, and better outcomes. So these are two examples that we're using, and several others are using several other agents along the same principle.
I think in adults, there was a large study in Europe that looked at the biomarkers and timing of CRT. And it didn't really, it was one of the second year, it didn't really seem so much of a difference. What are your thoughts on that?
It all depends on how early you use the biomarkers and how early you start the intervention. I think if you wait, if you cogitate, if you contemplate, and then think about putting them on some of these treatments, that biomarker has already told you that the patient has structural AKI. And the earlier we get them started, the better it is, I think. But I can't prove that to you right now. And really, that's the gold standard. The gold standard, like troponin, great marker. It tells us what to do. And if you do it in the right time, you get good outcomes. I think the same philosophy can be applied to AKI biomarkers, but I would agree with you, we're not there yet.
Okay. Well, we want to
Wonderful.
thank you for coming and being our plenary speaker. We would like to present you with a plaque
look at
to
that.
commemorate the occasion.
Where's
for
my mom?
Your office. Keep it in your protective covering here.
Thank you so much, appreciate it.
And then a little
Thank
thank you
you.
gift from the department for
Thank you.
coming to give us a talk. So
Thank you so much.
very much.
Thank you.